Topic of our discussion today is acute kidney injury and the use of NSAIDs. Okay, so certain important points in this talk article I will discuss with you. Okay, so first of all, let us discuss epidemiology. Okay, I have made a small summary by taking help from few other sources, and the main purpose of my video is to emphasize on the important points related to this article. This summary I have taken from other source, but the main source is that of the TOG article. So what is written in the epidemiology? Epidemiology complicates 1.4% of obstetric admission in UK. Okay, so 1.4% is very important. Now, most cases occur in women without pre-existing renal disease, and over 40% of AKI goes unrecognized by treating clinicians. Okay, so 40% of the cases go unrecognized. This is the overall incidence is 1.4% and 40% cases go unrecognized. Okay, now physiological changes in pregnancy are very important to know, because if we know about the normal changes, then we will be able to understand the abnormal one. Okay, so what happened in pregnancy? There is increased blood flow. Renal blood flow is increased and GFR rate is increased in pregnancy. Secondly, what happens that serum creatinine falls by approximately 35 micromole per liter in pregnancy. Okay, so renal blood flow increases, serum creatinine level falls. Okay, now coming to the abnormal values. Abnormal values, what happens that serum creatinine falls in the normal pregnancy, and new serum creatinine levels above 90 micromole per liter in the pregnancy should trigger investigation for acute kidney injury. Okay, so if we have 90 micromole per liter, then we have to investigate for AKI. Now, serum urea level of more than 17 millimole, despite the medical management, is a pregnancy-specific indicator for renal replacement. Okay, now what are the main causes of acute kidney injury? That is also a very important exam question. Okay, so we have to remember this list. The important causes of AKI include the preeclampsia, the HELLP syndrome, microangiopathic hemolytic anemia, acute fatty liver of pregnancy, lupus nephritis, renal tract obstruction, and drug use. Now, in the talk article, we have one list of different types of the kidney injuries. Like at early gestation, we have the specific conditions like hyperemesis gravidarum, the septic abortion, miscarriage, and acute retention. So, what are the clinical features in those cases? We have the clinical features like nausea, vomiting, tylism, abdominal pain, vaginal bleeding, and patient can present with a septic shock and retroverted uterus. In the mid trimester, what we have preeclampsia and HELLP syndrome. Okay, so what happens? The clinical features include the new onset hypertension and proteinuria after 20 weeks of gestation, and HELLP is a variant of severe preeclampsia. Okay, what happens along with the ureteral obstruction? There is increased risk of the single kidney, including the transplant, the autonomic neuropathy, MS type 1 diabetes mellitus, polyhydramnios, multiple pregnancy, and obstructed labor. We may have placental abruption. Patient may present vaginal bleeding, abdominal pain, and uterine tenderness. In acute fatty liver or pregnancy, patient presents with malaise, anorexia, vomiting, polydipsia, jaundice, elevated transaminase, hypoglycemia, lactic acidosis. And in case of the microangiopathic hemolytic anemia like DTB and HUS, we have platelets consumption leading to the hemolysis and end organ damage, for example, renal failure, neurological symptoms, and presents in the second and third trimester and postpartum. Now, in the peripartum period, like we may have chorioamnionitis, postpartum hemorrhage, ureteric injury, and NSAIDs. Patient presents with tachycardia, fever, uterine tenderness, abnormal logia, prolonged rupture of the membrane, hemodynamic instability, operative delivery fever, leukocytosis, pain, persistent EDS, and hyperkalemia, exacerbation of hypertension, and fluid retention. Okay, and any gestation patient may present with urosepsis, lupus nephritis, glomerular nephritis, interstitial nephritis, renal stone disease, and intravascular volume depletion, and each of these are having different sinus symptoms. Okay, now NSAID. NSAIDs can cause acute kidney injury as well as cardiovascular and gastrointestinal adverse effects. NSAIDs should be avoided in the preeclampsia, volume depletion, acute kidney injury, and the chronic kidney disease. When NSAIDs are used, ibuprofen has best safety profile. It should be used with the lowest effective dose and discontinued as soon as possible. Okay, thank you so much for your patience.